and welcome to a few of you who have joined us for just this afternoon. It's always nice to see more faces in the group. My name's Lorraine Shields, and we've had, I would say, a very interesting and thought-provoking morning in looking at 4 projects, as well as having our keynote speaker. So we'd like to proceed this afternoon with the next group, and I'm actually going to moderate for the group as well. And this group is a group of 5 students, and the focus in this afternoon will be around health promotion and disease prevention. Because there's 5 students, we're just a little tighter for time than we were this morning. So what I'd like to do is everyone has their 15 minutes to present, and then we'll do 2 or 3 minutes of questioning. So I'm hoping Carmel can help us keep on track with that. And then if there's time at the end, we will give you another opportunity for questions as well. So Alexa, I'll turn it over to you and let you begin.
Thank you. Good afternoon, everyone. My name is Alexa Diakino, for those that don't know me yet. And I have a serious task of making everybody do not fall asleep and after lunch. And I think it's the hardest part of this presentation. So I'm here to share the exciting adventure I had doing my practicum at the Ministry of Health in the Population and Public Health Division. And I have a very long name, a comprehensive picture of chronic diseases across the continuum of care, but our focus is on diabetes. I'm gonna have a slice of the project, which was quite huge to cover in 15 minutes, but I think you guys are gonna like it. So the need. Why do we have a need to focus on chronic diseases? The points I could get is that it diminishes the quality of life years for the population. It contributes to the burden of healthcare costs, and it can be prevented or at least delayed. So some of the chronic diseases share the same strategy, preventions, and they are complex and they need multi-factors interventions. Did you know that 9 million Canadians are dealing currently with diabetes or pre-diabetes? And 90% of the total of those cases are type 2 diabetes, which can be preventable. This is according with the Canadian Diabetes Association. In BC, 8% of the population is currently with diabetes. It doesn't seem like a big number, 8%, but it's the equivalent of the greater Victoria population. I would like to introduce Claire, and I have to make a disclaimer that Claire could be from any race, age, or population, and I want you to look at her and see what can you tell me about her or her health. It's hard to tell, right? She seems happy, she's outside, and there's not much we can know about Claire. But when you look a little closer, you can realize that she's a smoker. She leads a sedentary lifestyle, and she's struggling with her healthy weight. So Claire could be one of the people that are dealing with pre-diabetes, and she's not known yet. She doesn't know because there's no symptoms. Pre-diabetes is when your glucose levels are high, but not high enough to be classified as diabetes. But even looking further, we still don't know about Claire is that she may not have access to affordable, healthy foods. She may be dealing with a very stressful, low-paying job, and she needs to raise her family on that. So that increases her stress reliever as smoker, so she smokes more. And she may be living in an unsafe neighborhood, which doesn't allow her to go running or cycling, and well, joining a gym is completely out of her budget, right? Why I'm talking about Claire, I know this is an individual, but we're gonna use Claire as an icon, because we are focused on population health, and Claire is just a little glimpse of part of that population. And it makes a great parallel to talk about project. So the uniqueness of my project. We had a challenge of gathering indicators that could look into chronic diseases, but in this case diabetes, across the continuum of care. So looking at primary, secondary, and tertiary prevention. And with that, we would compose a whole picture, just like with Claire. We're not just looking at one part of the prevention. If people are exercising, or if the obesity rates are rising, but we are looking at every aspect. And that's quite challenging if you think about you have to go across silos to gather those indicators and join just health prevention with health services, which usually are separated. So the continuum of care, as I was explaining, it goes from the primary care, secondary, tertiary prevention, and it affects different populations at each time. So in the primary prevention, you're going to be looking at the whole population, and usually healthy individuals, because your intention is to avoid the disease to develop. And for sure, you're going to look at lifestyles, because we all know by the literature that it's a great influence, although it's not the only thing, as we have seen with Claire. The secondary prevention, it focuses more on individuals at high risk and in complications. So they focus on early diagnosis and lifestyle changes. For example, people that already have diabetes, but how are they feeling? Are they conscious about that and smoking less? So the indicators are looking at the obesity, some of the same indicators, but focus on that. And research has shown that people with advanced stages of diabetes take care of that part. So they're doing their part, but policies are supposed to help them do more. If they're, as Kathy was talking about, the inequities, you need that component to be too. So, and the tertiary prevention is like preventing an early mortality and the complications, because you're going to have certain complications. For example, with diabetes, there's amputations that don't need to take place if all the other components are in place, and we're doing a good job. So, at primary prevention indicators, like I said, I have a list of 20 different indicators, and I'm not going to talk about all of them, otherwise you guys are going to fall asleep. But primary prevention indicator, I'm going to say that we had obesity levels, physical activity levels, healthy eating habits, but also proportion of babies with high and low birth weights. And that was an interesting aha moment for me with the literature, because I would see that people with high birth weights could be developing maybe later in life diabetes. They would be at more high risk because the mothers could have gestational diabetes. But the literature shows that even babies with low birth weight have the same risk, and the curve, the graph would be like a U-shaped curve. So those two indicators would be important if you want to do work in prevention. So having those indicators would give a snapshot of the population in BC, how they are doing for that, right? But there's more to it. We need to focus more than healthy behaviors. So to ensure that we have population health, we have to put the social determinants of health in place. So we have to look at socioeconomic status, education levels, housing conditions. I'm not used to math, sorry. Environmental factors as well. Job opportunities. So those are a few of the determinants of health that will have a role to play in those healthy behaviors. So we cannot like I put the slide here because I don't want anybody to forget and think that it's just a blaming the victim type of attitude putting those indicators. So another aspect of my project is that it dealt a lot with data. And we all know, some of you guys will still get to know, that data can be very interesting, but very tricky sometimes. And traditional indicators of public health would be incidence, prevalence, mortality rates. So here we have BC data on diabetes. We have prevalence, and we have the incidence and the prevalence. But those are two different graphs. And would be interesting to have that, that incidence compared to other provinces in Canada, so we know how we're doing. I can tell you guys that BC is doing not too bad, but it could improve. And that's one thing that when you're working for the Ministry of Health in BC, you want to do. You want to improve your province. And the way we do is like that comparison would be between health authorities. So we would know the regions are doing how they're doing in a certain way, and maybe investigate further. Why is this health authority doing better than the other? What are the factors that are playing a role there? But one point that I would like to resolve here is this. When we have a crude rate for prevalence, for example, it's interesting because you can come here and say 8% of the population in BC have diabetes, and that calls people attention. But the standardized age data will give you more information because we all know that diabetes is a condition that it affects a lot of people at an older age. And we have to picture that a lot of people like to retire in BC. So we're going to have more population that is in that group, the category. So when we put a standardized age data, we can account for that. For example, another example here is the diabetes costs that in this graph is compared between 2001 to 2010. But it shows like hospitalizations. The blue line is hospitalizations. The red one is MSP, and the green pharma care. But one of the other things we have to be critical about this graph is, are those costs in comparison? Because we know that, a jug of milk in 2001 costs quite differently from a jug of milk in 2010. So when we see an information like that, we know that it's rising and it makes sense, but we have to be critical, like how this data was gathered. They did, the analysis proper to compare those costs throughout the years. And this is the mortality rates for diabetes from 1987 to 2011. And I use that for a case, the students that were in the cohort knows, is that I discussed this because they changed in January 2011. They decided to change the coding, the way that they put mortality rates. People don't die from diabetes, but there's a lot of more incidents of cardiovascular disease that are the result of being with diabetes. So by changing the code in 2011, we get this peak, and it seems like a lot of people die from diabetes, which cannot be the case, but it's just that they honor that association. But it makes you wonder too, how is this graph would look like if we could go back in time and put those cases in place, right? Those associations that we were just leaving out of the picture. So it's a good positive point that they are doing that, because that's the thing with chronic diseases. They have other complications. So this is the complete form with the 20 indicators that was created at the end of the project. And from the secondary prevention, like I said, there's a lot of the lifestyles associated with people that already have diabetes, but also tests to measure your glucose level, or tests that will measure all the damage, the little damage that you don't see, but that is happening behind the curtains with the diabetes. And and how we're doing for that. We know that the population is not doing so well, and that's the part where public health mingles with health services, because you're going to have that component to analyze if people that have diabetes are not taking following the guidelines to do those tests and see their conditions, they're going to have more complications. So how can we avoid that? That's when public health would just interfere, and even though it's health services, do empower the people that can make policies, programs, and services to focus on that. So that's the implications of public health. The benefits of this project, even though it's something that can unfold in many different ways, because it can it can associate with indicators that focus on the social determinants of health that were not included in this list. It can include information about certain populations, like Aboriginal, that we know they have a higher prevalence of it, and they can together empower people to create new policies and services, and also give transparency to the BC population, because they want to do the final product for each indicator would be something that would go in the website of the ministry, looking like that, having the indicator, having the definition, how the data is collected, how we're doing in comparison between health authorities. I would like to acknowledge all the people, and I'm not going to go into names, but all the people that helped me to go with this project. My professors for all the guidance, my supervisors in the ministry, my co-workers, and all my classmates that were there for me. It takes a village to do something like that. That's what I always say. So thank you very much.
Thank you, Alexa. Questions?
Thanks for being the first bold one to use a Prezi. Wasn't clear, I may have missed it because I came here a bit late, but you talked about being able to compare BC to other provinces, you talked about being able to compare health authorities, but how far down can this data go that we can use it to make comparisons within health authorities? Because comparing one population of 500,000 to another is not all that useful in comparison to local level. So how far down does it go?
Well,
and still be reliable?
Yeah, that is a tricky thing with data. I could have brought some data from the diabetes document of PHCA that had a comparison between the provinces, but it would go only until 2008. The graphics that I tried to put here were more up to date, and that's the part where you lack, because usually those reports, when they gather all this information, they come once in a while. So to get this up-to-date information is harder, and that's the big challenge of this project, right? To have this on an ongoing basis, so you can have that comparison, but also understanding. And I think that there's a need in people to compare, to know how they're doing in comparison to others, but I think you have to take in consideration the challenges, the population of the area. When I was showing people that work with data, the findings I got from different health authorities, they already knew, because they do with the analysis that go further down what I did, they already knew why the health authority doesn't do well. And sometimes it could be that because they don't have a good data gathering in place. So it is not fair to compare. So to answer your question, sometimes. But people do have that necessity to make sure how they're doing and to start from somewhere, right? I think that the discrepancy will lead to finding out why is this happening. So,
but my question also is below the health authority level, down to smaller populations. Is the data there, or how sensitive is it as you get further down?
just health authorities, yeah.
Okay. Another question? Anybody else?
I was just wondering, on the one-page example, is that something that's like for future development, or is that?
Yeah, that's an idea to be developed. Look, because my part was just doing the data analysis. So I gather the indicators and I create a grid. And people just they know where to get it, so they have to just grab it and put it on the website and all the indicators, because the BC government wants to show transparency what they are doing, right? So if people are having those tests and there's a high number of people, they're doing a good job. So it works in many different levels. It works good for researchers as well. For us to have that information would be awesome, but it's a project, so.
Right on, thank you.
Anybody else?
Alexa, I want to ask you a different kind of question. And it's really about what isn't presented here, but was experienced by you. Thinking about working in a setting in which there is, for other kinds of reasons, so a security breach of data and so forth. This is all about using data. Could you perhaps just comment briefly about your observations working in an environment in which the quality of work relations suddenly change as a consequence of some sort of external factor? And because it's a reality of working in government structures, right? And I think you, among all of the students, have had perhaps the front row seat in a unit in which that is a particular issue. Right? Could you comment briefly about that?
Yeah, I try not to, because I had all the discussions, the weekly discussions. I think I put my 2 cents about it, and it was really a challenging experience, which was not experienced for other colleagues that were doing their practicums at the ministry, exactly because of the data. And it's to me, it's sad to see that data is so important to us to do all the work we do, and for government to do the work they do. But at the same time, it can be so tricky and sensitive, and you have to be able to do it in a way that you can ensure people's privacy, because the consequences of that can be huge. People lost their jobs, they lost their careers. So when I went to this division, in the beginning was really gloomy, and I was warned by everybody, but it was just like I didn't get the scope of it until later on, and working more and learning more about data and how this can impact so many people's lives. So it's a catch-22. You have to have that, but you have to do it in a way. You have to gather the data, but you have to do it in a way that it ensures that privacy and security, so people don't lose, like the population doesn't lose faith that it's going to be used for good. But I don't know if did I answer your question?
Yeah, I was really very interested in just the impact on day-to-day working conditions. You think about the role that work plays in one's life. It gives us identity. It gives us meaning. If we have jobs that we enjoy, of course, clearly, not everybody has jobs we enjoy, but and when that doesn't happen, that has a certain health impact. And you're working in an area in which a certain event has happened that suddenly changes completely the dynamic of work and so forth. And it just seemed to me an interesting kind of learning experience that was not intended, but experienced nonetheless in a very particular kind of way.
Yeah. Yes. Yes.
Thank you so much, Alexa.
was placed in, and actually it's a placement that I sort of recruited for myself. So like for first cohort, for second cohort, if you register something, just go out at the door, because I did that, and I secured a very interesting, very supportive, and very, I learned a lot from it. I worked on developing a program called student-led wellness clinics, and that's here within the campus of UVic. Just a slide on the background of my program. I was placed with the University Health Services, that's located here at campus. And it's a sort of like clinic, and it's a really an interesting place to work in and to be a part of in performance, because it's sort of an integration of primary care and public health under the same roof. It offers a whole spectrum of medical treatments and counseling, from traveling, from vaccination, child vaccination, to the big pressure or the big challenge around campus of mental health and counseling around it. It was a very nice place to be in. Again, I did that because there's a whole new sort of movement within the UHS of reorienting towards health promotion, not just being medically focused. And this has been like this sort of new direction, new group direction has started for a couple of years now. And it comes from this emphasis or this really sort of close relationship between the success, the academic success or even life success for students, because academic is just one aspect of their success, and the health of students. So I'll go back to it, I promise. So my role, my specific role within the University Health Services was to develop a program for this peer-led education and sort of support program, and to present sort of I was faced with the program for that period of time. So I was engaging in presentation to classrooms, to certain faculties, to just spreading the word about it whenever I can, because a lot it's mainly based on recruitment and buying in for the program. So I did a lot of networking, organizing meetings, and I also took on sort of a role of a public health nurse within the University Health Services. So I participated a lot with whatever was offered there, what was going on, and I did do things in my own, and I did support other sort of initiatives that were going on, something like the body image awareness event that I sort of took a certain role in, and it was really interesting to just be exposed to the whole environment. And the idea of the program actually came from a cry out from within the faculties of UVic, who approached the director of healthcare, the director of health services, and they said, our students are stressed to the max. We need to have something we need to support them better and further for their own success academically, and also to become better skills for life. And so that's how the idea came. And when I knocked at the door and I approached for a practicum, that was sort of the whisperer brand. So we figured we'll take it the extra step. And I mean, the situation with UVic students, it's sort of common with most of, it's not all campuses, which is there's a high stress of academic, high level of academic stress. There is a mental health issue is huge, mainly depression among university students. I mean, we have better data and statistics from the state, but again, it's sort of a reflection. What little we know, what data that are available here for us, sort of reflects a very similar picture of mental health. For really, about 25% of university students suffer from mental health issues and maybe depression. Again, the social sort of component of university living brings on partying, brings on binge drinking, brings on unsafe behaviors like unsafe sexual behaviors, which is a has immense risks to their health and again to their academic success because that lead to higher dropouts and less retentions, and this is something that universities do not like to see at all. And also the focus of the program comes from the documented benefits of their peer-to-peer initiatives, which the literature review shows that they're very successful in supporting students. And also there's a sort of, this program doesn't also come from a very vacuum, it comes from something that's going on here around campus, which is called the Neighborhood Nurse Program. That's me, and that's Sarah Woodward, which is my preceptor, it's a booth that carries sort of a theme of a health or a wellness that goes with the life cycle of the student. So it could be an infection, we have to prevent the flu, around like flu season, it could be around binge drinking, or even like here the one is what's like just spring. And sometimes it's how to study, like study tips, and it's a very relaxed, very trusty, very sort of welcoming environment. So really, it's very interesting to see the students gravitate towards the booth. And this is something Sarah and I did during my presentation every Tuesday in International Commerce, but also we sort of supported the nursing students with practicum workups, and they did carry that in one of their residence building every Wednesday evening, and they had really great success. And it's a double sort of benefit because the volunteer benefits from that, and also the student that they're receiving it. I'm going to have to go back. Here is the promise. So again, to tie this with my colleague Alex's presentation, this is just one face, Clara is one face of many faces of the population of UVic, which is with the academic stress, and then the choices of like sort of there is a culture of binge drinking around universities, especially first years, and then how that could lead to mental health. And it's sort of a multifactorial, not just saying that. It could be just because the onset of mental illness sort of falls within the lifespan or within the age group. But just that's just a glimpse there. So that's just a quick review of what does the literature tells us about the benefits of peer-to-peer initiatives. So because it gives them a meaningful way to participate in their communities, expand their knowledge and experience, enhance interpersonal skills, provide ways for young people to demonstrate capacity, and also takes that sort of isolation. It makes the idea that I'm asking for help is not a weird one. I'm not alone. It normalizes that process. So the vision of the program is that I heard this word before earlier with the speaker, keynote speaker, which is cross-pollination. I use that a lot in during this the process of this program, which just brings students from all faculties together. Students at UVic tend to be segregated in their buildings. They have their cafeterias there. They have their food. They have their friends there. So they're all, and they don't. Some students, like for an example, between nursing and medical program, we don't get to see each other. So I'm a product of the program here, but we're so two different entities, and when we at the workplace and we're working hand to hand, side by side, at each other's side, and when we lose this opportunity of working along each other within school and get a better appreciation of interprofessional sort of practice, and that's one idea of the program. Besides its health benefits, it's to bring students who have keen interest on wellness and from different faculties to work with each other. And this also goes along with the UVic key strategy, which is it mentions here the foundations of a healthy university community, which is inclusion, respectfulness, accessibility, safety, and coordination. So I had sort of two parts of this project. I had a report to present, which was I sort of I wrote I planned a program, but my role within the UHS was sort of to be the sort of face of the program, and also to develop a format or a blueprint for how the program is going to look like. And it's sort of a preliminary. It's not like set in stone, but I think I did a good job. So yeah, I'll go back to this, which is I followed the planning model, which is developed by the communication unit at University of the pre-planning and project management step one, step two to conduct a situational assessment, which was really that was really an interesting part that when I got to do, because I learned a lot about UVic that I after spending 2 or 3 like my master's and part of my nursing education that I didn't know about. So that was really neat to learn. And then identifying the goals and the strategies and the development indicators and reviewing the program plans, which is put in a sort of a logic model that I still do not like logic models, by the way. But I mean, I do my best at trying to put it all together. I think I'm going to have to come up with a different model during my life that'll work fine for me. So challenges that I learned from working in this and during my practicum, what I learned is that within this conceptual sort of environment where you have students who really like have a very heavy workload and it goes like, okay, the semester starts, okay, and that's part of the life cycle too, is their academic workload. And then you find like, wait, like I was sort of pitching this program to different classrooms and it's amazing the kind of feedback that I got. That I even emailed my first group and I missed 2 people, which was like the first list that I got because I couldn't make sense of their like handwriting. And then I get an email from them saying, you missed us. We didn't hear from you. So back then I said, oh my gosh, this is good. This is like, we're gonna have what, 100 people in no time. But then as the semester progresses and the workload gets heavier, so you see the participation slumps. And it was really devastating for me because I just wanted it to. But then I had, part of the challenges is this is a reality, and I had to sort of learn that reality and look within and then strategize and say, okay, so I couldn't get the students to come to this meeting. What am I going to do? I'm going to go to them. And that's, again, another thing that I started doing with my receptor, and we picked up a few classes, and we went and presented for them. And the idea is also just to keep that going. Like, I presented also to the Island Medical program during a fair they had, and by the time we got there, almost every student knew about us. And the other thing I think is that, yeah, there's a need definitely for extra support because this maybe sort of falls into the nurse educator and programs I was my receptor. And also that networking really, again, needs a lot of time, a lot of commitment, very busy faculty. I mean, just to sit out and do notes sometimes was like exhausting and like waiting for people to respond and then like it's a lot of work, but then it happens. You need patience and you always need that contingency plan. If this doesn't work, where's the next step forward? So the conclusion is that that's again what I learned from doing the situational assessment, that there's this great, really supportive environment at UVic for health and wellness. There's a lot of resources. There's very knowledgeable faculty. There are students who have a wealth of information, knowledge, approach, and even excitement. Like we have students that come to us and say, what is it that you have that I could help? My friend is really having a downtime and I feel like I need to do something. And also, again, what my conclusion is that peer-to-peer sort of the program, the student-led wellness clinic program is a sort of a good fit because again of the age group and the benefits of peer-to-peer-led initiatives, and also because young people from the literature tend to trust their peers more than professionals and turn to their peers before they turn to professionals for help. Implications. I'm going to actually show this first. This is a tablet that I developed for my placement for University Health Services, and it shows what are the topics, what are the resources that we sort of had to scan and find what are the resources available for us, how we're going to go about recruiting and selection, how we're going to go about training. And it's not an easy job, and it's not going to be easy, but it'll happen. I can see it happening, and maybe not at the level that we have at the beginning, but it'll get bigger. And I do see that from the excitement that this had received. So now I have to go back. So the implication for public health. So again, the relationship, this really close relationship between health and between academic success. So creating such a program sort of reinforces that. It provides, look at, there are 20,000 some students in one campus at certain points. So this program and other programs likewise just gives an opportunity to reach this great number of people at one place or one, and during a very important period of their life, very appreciable too. And also that the literature shows that what people learn about health at this stage of their life, they carry it for the rest of their life. It decreases the students' burden of disease, helps foster community leaders, because as a volunteer, you're definitely taking on a good sort of engaging role within the community. And my acknowledgement here, thank my professor, Dr. Judy Burgess, who was director of Universal Health Service, all my professors from the school, my lovely husband, and I said in his unique way, and then my children, who really give me the reason to keep me doing what I'm doing.
Time for one question, and then we'll need to keep going. So we're getting shorter on time. So anybody got a burning question? Trevor?
Thanks, Nazareth. So one of the challenges I see, and I just want you to reflect on it, is you commented about how much the student participation went down over time as the workload increased. That to me sounds like a real challenge for this program, because the time when people most need support is going to be towards the end of term, probably when they are the most stressed, and yet that's when the participation on the part of peer leaders is going down by the sounds of it. So what are your thoughts about that and how you deal with it?
Yes, and this is a huge challenge, and a big job. And I've sat in really very productive meetings, and it seems that the only really solution that we work with for that is to give some kind of a credit. And not exclusively for this program, for other programs around campus, some academic credit. Even acknowledgement, like even if it's not towards like 3 credits or 1 credit, even acknowledgement in your transcript would work. There is like within the Island Medical program, they're going through a review of their curriculum now, and they're going to sort of push towards that. They have also a community, so a course that I can't remember what it's called, which they do a community sort of placement or community work that's credited. So that could be part of it. But unless there is some kind of a credit, a university credit that attached to these types of programs, you won't give the amount of, or the number of committed people, or constant sort of commitment. What is the other thing that I wanted to say here? There's another program around campus, which is the Peer Hoopers program, and it's a very successful one. Like they run about 50 volunteers or more every year. They turn down plenty of applications. It's grounded. It's been there for many years. It's very sort of like when I was trying to solve this program to students, my two things that I would say, or 3 things that I say, this looks great in your resume, it looks good in your graduate school application, and you know what, like whatever you do in life, you can use this. You can say, I've been a part of this. So that's, I think, the peer homework program sort of hit those points very well, and the students sort of got it. This is why there's a very good sort of demand for it. Like it's waitlisted. But it's been around for 26 years this year. So this program will get there. But to get there faster, a credit definitely is it.
Okay, thank you so much.
So how do I tell, is this working now? It's working, yeah? Okay.
So I'll turn it over to you, Margaret.
Okay, great. Oh, I think I just shut it off.
Here it is. Corey?
Oh,
Okay.
so we're all set. And can everybody hear me? I think I hear a bit of an echo, so I think we're good to go. So my name is Margaret Moore. I've met most of you, but I know I haven't had a chance to meet Victoria or Lynn face to face yet. So hi. Okay, so I'm actually from Toronto, so I've been doing my placement there at the Heart and Stroke Foundation, the Ontario Provincial Office, which is right at Yonge and Eglinton. So it's in a perfect location there. When people hear Heart and Stroke Foundation, they sort of think of fundraising or Jump Out for Heart or door-to-door campaigns, but really that's only half, not small, but a huge part, but half of what we do. So there's a whole other side of Heart and Stroke which deals with mission, the content of all our programs, cardiovascular research, funding university programs. So that's the side that I was involved with, and within the mission team there's research and health promotion, which is a huge department as well. Within that department there's the evaluation team, which is very small. There's the manager, there's the senior eval specialist, who is my supervisor, Laura Garden, and there's one evaluation specialist, and then there's myself. So a small team, and as well, we just underwent national unification, which I always had thought Heart and Stroke was a Canadian thing, but it wasn't. We were 10 separate, totally autonomous provincial bodies. So just as I started, actually, we had become unified for the first time. So now we have 10 united provincial bodies, 130,000 volunteers, 2 million donors, and 800 staff members. So you can see that volunteers really are the heart of our organization, and they really do outnumber the number of staff that we have. So in terms of the national unification, that also meant that our first ever national strategic plan was being released just as I started my program. It actually was released a couple weeks ago. So everyone was kind of holding their breath to see what programs would be cut and what wouldn't be, and especially Ontario, we have a lot more staff than, say, Manitoba, so we knew that we would be getting cut a lot more than other provinces would be. So that's the background. Okay, so the portfolio I was working with was Heart Healthy Children and Youth, and the Ministry of Health in Ontario just made one of their priorities for next 2 years, I think it is, children's health, and as well as capital literacy. So within the portfolio, there is the Heart Healthy Children pilot presentation. So that's the project I was assigned to. And essentially, it's a pilot taking place in Alberta, Saskatchewan, and Manitoba. So it's engaging volunteers to make school presentations, promoting healthy eating, physical activity, and grade 4 classrooms across those 3 provinces. There was already the same program in Ontario, but because of capacity, you couldn't compare to the office sizes. So it was starting fresh with this pilot. The overall goal was not looking at the effects it had on kids. Like, obviously, this program's not going to change obesity rates. What we were interested in is looking at understanding the resources required and benefits of volunteer-delivered presentation to further the engagement of schools, but more so to further the engagement, deepen the engagement of our volunteers because they're so important to us. So here's a look at our national team. Our program manager was in BC. She was an independent consultant that we hired for the program. And again, myself in Ontario, and each of the pilot provinces had a team lead. 2 of them also had a volunteer coordinator, except Saskatchewan. Linda Foster was the team lead as well as the coordinator, so she was a one-woman show in Saskatchewan. Okay, so I had 2 deliverables. My deliverable, so just have a look at the second one. That was for Heart and Stroke. I did a report, an interim report on recruiting. So how many volunteers did the provinces want to recruit versus how many did they actually, what methods did they use for recruiting? Did they recruit online? What were the processes and policies involved, which are really different across provinces. So for example, some provinces do require that you have police reading as well as honorable sector, some don't. Some provinces have never had volunteers going to school, it's always been heart and stroke staff. So it was really, really interesting, and I actually presented to heart and stroke a couple weeks ago. So I'm not going to be talking about that at all today, just because of time. I'm only going to be talking about my unit deliverables, so my final project, which is a scoping literature review. And I looked at identifying best practices of volunteer recruitment in a nonprofit health advocacy setting. So I wanted to make it as specific as possible. So in red, you can have a look at my actual research question. So looking at what's already known, basically the title of the paper. And originally I wanted to look at training and recruiting as well as emerging practices, but my first kind of glimpse at literature said there's no way, there's too much lit on recruitment. That would be 3 separate reviews in itself. So I focused only on recruitment. So in terms of methods, consultation with Carol, actually, we haven't met face-to-face either, from the library. Decided to do a scoping review similar to that described by our team already. Okay. And my database, I only used UVic Summon and Google Search. Search parameters are listed there. They're pretty straightforward. All online, no geographic parameters, English only. Pretty straightforward. And that was just a list of my Pico search category terms, just to keep my methods, I guess, transparent so it can be repeated again. So I found a lot of results in the academic literature as well as through Google. To narrow it down, I first looked at the titles. So many search results were for recruiting volunteers for clinical trials, which is not relevant to my project at all. So I narrowed it down to 7 database articles and 9 search engine articles that were actually included in my paper. And I realized that's a low number. This is partly because there was not a lot of literature on this specific area. So we will talk about that in the gaps in a minute as well. So what I was able to do with those articles was group them into 4 thematic areas. So defining what an organization needs volunteers for. That's really important because, again, in provinces like Manitoba, Alberta, where staff has always done the work, it's hard for them to let go and give volunteers an actual meaningful piece of work to do. Finding and attracting volunteers, so reflecting on organizational image, why would one want to choose us as opposed to like cancer care, we want to be the #1 choice for volunteers. Policies, which is really, really important in terms of liabilities. You have to have certain checks in place when you take on volunteers, especially when you're going to schools, obviously. And then resource considerations. So there was some literature saying in order to retain volunteers, you have to give them something that makes them feel needed, so that maybe more office space. So this is Claire, just to continue sort of with the other presentations. And thinking of Claire as someone who wants to volunteer again, Heart and Stroke, what are we doing to motivate volunteers to volunteer with us? Is it our mission they're interested in? Is it are we giving them reference letters? What is it that's going to make Claire want to come to us as opposed to another organization? And not only that, but deepen her engagement. So take on a little bit more responsibility and also volunteer long term as opposed to a one-day fundraising event. So here is the gaps in the literature. Number 1, few studies focused on volunteers in health advocacy. Like I said, there's a lot focusing on fundraising volunteers, a lot focusing on clinical trial volunteers, but not so much on mission volunteers. Again, long-term, not a lot of studies on that, as I mentioned. Directions for future research. I saw a lot of this in the Google search, emerging practices, recruiting on Facebook, recruiting on Twitter, which organizations like Heart and Stroke don't do because there's such a long approval process to go sending to Facebook. And I was at the Ontario Public Health Convention a couple weeks ago, and somebody said, why don't you post it more on Facebook and that kind of thing? And they're like, well, we do, but there's a 2-week approval process. And by then, the information's dead. Like Twitter, Facebook, it's not something, that's not how it works. So you need to have things move quickly. That's the whole kind of concept of social media. The problem with this, there was not a lot of academic literature on this, particularly because it's new. So that would be a good place for future researchers to look at. In terms of strengths of the review, it was scoping, so I got to include a lot of articles that would have met the high quality standards of a strategic systematic review. I didn't really limit the types. Oh, I already said that. Okay. The methods were transparent to some degree, so I tried to chart my data, not the data, the articles. I went through parameters, all that kind of thing, so it's to some degree repeatable. And the systematic review was easy for readers to navigate. In terms of limitations, and unfortunately there are more limitations I find, the broad scope, well, was a good thing. It also was a little bit detrimental because I couldn't go into depth into each of the subcategories. Again, rigorous assessment of study quality, I just didn't do. I didn't set it out in my methodology. I wanted to include as much as I can, as much as I could. Search, planning, and charting took way longer than I thought. I heard scoping review and I thought, oh, so easy, like I'm definitely doing one of those. But, but then when you're trying to make it repeatable, so somebody's reading this can do it again, you realize there's so many charts. You have to be very methodical. You can't just Google something and then say, okay, great, I have what I need. It's so that whole process took a lot longer than I expected. So I think that in hindsight, I would have left a lot more time to organize the thematic findings as well. And detailed methodology, it's hard to say. It may lend itself more to an audience of researchers, which is, I had intended to use it for public health professionals as well as public health, like volunteer managers in heart and stroke and outside of heart and stroke. But for them reading this, they're not going to read it. So I think, as Lynn said, something like an executive summary, one pager, that's a lot more practical for professionals. Okay, so conclusions and implications for our public health field. Number one, this document can be used for heart healthy children and youth coordinators in other provinces. So the whole, in the beginning of the pilot was that this will have some really great results, and we're going to be able, pending the strategic plan, have funding to expand it to other provinces. So say, for example, Quebec wants to do this program next, they can have a look at the lit review and say, okay, what are the best practices? What do we have to do? The findings are transferable to other heart and stroke programs outside of heart health in children and youth because, again, so many of our programs use volunteers. Transferable to other organizations. Actually two of the provinces I spoke with had brand new volunteer managers because best practices are trying to have someone whose specific job it is to speak with volunteers as opposed to having one person do everything. They want to have one specific person deal with volunteers. So a lot of the staff are brand new and they're not exactly sure, they don't have experience in the area. So useful for them as well. Again, we identified gaps in literature, so next steps for public health researchers. And this is all important because volunteers in public health advocacy, they're really, they play a huge role and we couldn't do our advocacy work without them. So it's invaluable and I think we really need to put more resources into good volunteer management. Okay, so in terms of acknowledgements, everybody at Heart and Stroke, the whole team there, the national team as well, you, Vic, Kathy, Lynn, the second leader, Victoria and Betty, Carol, and all the other faculty staff. Cohort number 1, as well as cohort number 2, because I know some of you guys are here too today. And some references, contact, and before I go to questions, I don't know if you're on LinkedIn, and even if you're not, just I found that public health in Canada is so small because I went, so at Heart and Stroke about 5 years ago, I needed a speaker for an event I was doing. And then I wound up at Heart and Stroke again now, and my speaker turned out being at the cubicle next to me. And she introduced me to another woman named Nadia. She was like, what do you think? Who are some of your professors? So I told her, and she's like, wait a second, Trevor. Do you mean Trevor Hancock? And I was like, yeah, I do actually. And it turns out when she was doing her master's at U of T, I guess Trevor was teaching there as well. And so then this morning I had an interview for the government of Nunavut actually. The girl I was speaking to, oh, you Vic, do you know Dr. Michael Prince? And I'm like, no, we haven't met. And then I looked at the syllabus for this summer's policy course and oh, who's the boss? It's Michael Prince. So small world definitely in public health. So anyway, that's my presentation. know if you have time for a question or two.
Thank you so much, Margaret. Questions?
I'm good with that.
Not at all? Okay.
I should be able to remember reading this from your report, but I can't. Did your literature search also include gray literature?
Yeah, so sorry, I should have mentioned. So I searched UVic Summons just for the academic articles, and then I did a Google search that was for the more so for gray lit. It did return a couple academic articles, but it was like organization, volunteer association at BC, that kind of thing as well.
So there wasn't really much literature that you could find for, like here in Victoria, there is a volunteer Victoria organization, but organizations like that apparently haven't put anything out that you could find anyway.
There was some, but it just wasn't specific to volunteering in health advocacy in nonprofit. So it might have been like how government doesn't use volunteers in the same way that we as nonprofit does. So I think it was just specific, like having all the components in one sort of source is hard to find.
So have you identified your PhD topic from this?
Okay, okay, now I thought of a question. I wanted to know why did you narrow it to health advocacy organizations when, as Lynn just pointed out, there are lots of organizations in the community that actually do health promotion, even though they don't call it health promotion.
Yeah. You know, I just, when I started, I thought that I would do something that would specifically be relevant to heart and stroke, but could be used by other organizations as well. And health advocacy, my supervisor had been saying it's so important, but people don't, it's not as official, I guess you would say. It's kind of people working underground. It's not always built into an organizational mandate. But being in public health advocacy, like whether it's for heart disease or mental health or anything, it's so important just in a health setting. I totally didn't even answer your question. I kind of didn't forget.
Well, I really appreciate the way that you were quite clear about your methodology and you provided us that detail, which really helps actually. I like that a lot because it really gives us a sense of what you did.
Yeah.
But it leaves me questioning too, because I'm thinking to myself, you didn't actually get a lot in terms of articles that you could use. It was like 13 or something, right? So, but if you had broadened it and looked at volunteer recruitment for nonprofit organizations working in the community, or whatever, you know, like that, and I think that would still be relevant, very much so, to the Heart and Stroke Foundation's work. I don't see how it's specific to health advocacy organizations is that all that helpful necessarily.
Yeah.
Just like, I don't know.
One of the reasons maybe too is motivations for volunteers in health advocacy are a lot different than volunteers in non-health advocacy. So for example, like the volunteers we had for this program, one of their motivations was they had a family member who was affected by heart disease or so it might have to do with that. So if they specifically have an interest in the cause, like in some health aspect of it, you're totally right. I mean, it would have been useful. I just had to pick something.
Okay, well, thank you very much.
So welcome to our rally getting set up. It's going to get you all to stand up, and because this is technology, it's going to get you to pull out any technology you brought with you today. Did everyone hear that? Oh, no, that's okay. I just have to get everyone moving. If you want to pull out any technology you brought with you today, like a laptop, your phone, a pen, thank you. Yeah. Any technology you think you brought today. There we go. All right.
Okay, now I'll turn it over to Marcy.
Are you about? So I'm Marcy. So yeah, I just wanted you guys to get the reason I'm the last presentation of the day, so just to get you moving it out. And I also wanted to just point out, this is one of the problems I faced in my project, was what is technology? So just gonna figure out here, I've got that from there we go. So yeah, some of you pulled out pens, other people pulled out glasses. The one technology I'm going to focus on, just as an example of technology, is information communication technology. But there's other technologies I looked at as well. All right, so I work for the Seniors Action Plan under the Ministry of Health, and thanks to Brenda Hyatt for being here today. She was my wonderful mentor, so I really appreciate that. The Seniors Action Plan came out in February 2012, and it had 6 themes. I was looking at the 6A, which is a review of existing best practices of seniors care across Canada, and also in other jurisdictions. So what my main focus was to do was a scoping review on innovative technologies that promote seniors' health at home. So one of the projects, one of the papers I found initially was out of Ontario, and it was the Ontario Health Technology Assessment in 2008, and it found 4 considerations that increase a person's chance of entering residential care. And so it's incontinence, social isolation, falls, and cognitive impairment, so dementia and Alzheimer's. What's also important to recognize is how these all live to play. So, for example, people who are socially isolated actually have been found to have higher risk of cognitive impairment, and vice versa. Someone with cognitive impairment is more likely to be socially isolated. The other thing that should be overlooked is the impact on the caregiver. So this report found that for people who are incontinent, it actually is the highest risk factor for caregiver burnout. So I looked at these 5 factors as one of the criteria to look at what technologies can keep seniors safe and independent in their home. And then there's actually a factor out there that reduces the risk. It's not a technology, but just wondering if anyone knows what factor can reduce the impact of fall, of the chance of a fall, incontinence. Thank you. I actually planted Jose because I thought in case we were all just but someone else got it. So yeah, it's physical activity. And the 7th factor I looked at was anyone over the age of 65, if there's any studies out there that focus on technologies for people over 85. So I identified 3 categories: monitoring devices, so telehealth, smart and ambient technology, robotics, which is housekeeping, and other home support services. The worst name ever for public health. Social assistant robots, which are actually really interesting, but I'm not going to talk about them. And then mobile phones and tablets. So I also, at this point in my scoping review, I realized that the technologies aren't enough. Seniors aren't adopting technologies, so I looked at why seniors aren't adopting the technologies. I won't be focusing on that for today because that would be another half hour. But what I will be looking at is just an example of mobile phones and tablets. So you all have your different devices out there. I wanted to just throw it out there. What do you think could be useful that you have on your cell phone, your smartphone, your tablet that could target these different risk factors? Yes? Excellent. No. Yeah. Yeah, did everyone hear that? Accelerometer. It's accelerometer, so you can use to detect fall. So there's actually belts out there that can have sensors plugged in to your cell phone. It can do 2 different functions. If the person feet is moving, it can detect that. It can also detect if someone has fallen, so if there's a sudden change in the person's movement. It can also, the sensors can be used to monitor physical activity and all of that. Anyone else? Yes, the GPS is huge, so that's the other one. And, oh, yeah.
Oh, you can call 911 from the
That's right. You don't have to, actually, I didn't even think of that one. So yeah, you can call 911. And and I believe, I haven't verified this, but you don't have to pay for any cell phone coverage. So you can call 599. I've heard that. So yeah, so GPS, gyroscopes, you have your phone, so you can call for help. You can track a person who may have dementia, so if they are wandering. And then again, the person with self-scoops.
You want it on the internet?
Yeah, I guess so. Any other ideas out there? What do you have on your cell phone?
They have banners in them. Yeah, your doctor appointments.
Yeah. Yeah, exactly. You're very good at this. I never saw that. So it has, because you have a calendar, you can actually do your appointments. So the next slide is just to show that you can schedule reminders. So you can do medication reminders. For incontinence, you can do reminders to go to the washroom, so you can avoid the event. And you can do also reminders for doctor's appointments. The other thing actually that Dan was working on too, was working in the same area at Can Assist, is linking caregivers. So now people have ability to link to multiple caregivers through either their mobile phone or their tablet. And then apps. There's an app that came out of the University of Toronto, and they've created, taken the WHO's healthy aging guidelines, and they've actually created an app so that you can find any places within your community that are accessible. And then apps for tracking your physical activities. So this is just an example of what Can Connect is doing in Can Assist. Because you have a camera on your phone, because you have a touch screen on your phone, it's actually been found to be really effective to look at people with cognitive impairment, and now they're looking to extend this to people with dementia and Alzheimer's. I was actually really surprised because I did another paper on people with cognitive impairment and found that touchscreens are actually a really successful application, far more than dials or keypads. It's just quite an intuitive interface. And so the example that Can Assist gave was you can actually do the laundry cycle. So if someone can't remember the steps to do the laundry, you can take pictures of each different sequence. And then they're creating a simplified version of Skype. So taking away all the background of extra dials and software and just having pictures of people that you recognize. And so that you can just, if they're online, you just catch them things if they're The other thing I liked is for they included in people today was I also found that touch screens are really good for infection control as well.
I couldn't hear that last.
Oh, touch screens are really effective compared to keyboards for infection control. So here's Claire again. She's now in her late 60s. She's with her granddaughter, and she's looking at what technologies exist for her to keep home in her home for as long as possible. So one of the things I found for the barriers for Claire is I couldn't find a lot of research on these technologies because it was innovative. It was really hard to find any evidence of how effective they are. But also the designers aren't creating technologies for seniors. And so what often will happen is a senior will go, I can't use this device, rather than going, this device wasn't made for me. Whereas younger demographics will actually go, this device is horrible, and go on to the next device. And in a really good interview I had with someone from in Pennsylvania, he commented how we always keep going, oh, baby boomers are coming. They'll be able to use technology. But the concern is that we're still having our designers make technologies for the youngest generation. So we really have to look at addressing how we design technologies for different demographics. There's also the social stigma. I heard it throughout, no matter where I did my consultation, but that technology and seniors just don't merge. And again, I think that's part of the research and design. And the reason why I love this picture of Claire is that it shows her with her granddaughter and actually just giving her a chance to use the technology, just trying to introduce the technology. Computer literacy is quite low in seniors compared to other demographics. I can't remember the exact stats, but a recent study came out to show that it is improving. But the computer literacy is also linked to the health literacy. So by ignoring one, you're ignoring both. And then there's a financial concern because the demographic that is also the least likely to afford it is the older women who are living alone and being socially isolated. So this is one of the projects that the Ministry of Health is working on. And it's looking with TELUS to do telephone care monitoring and using tablets to link different biological signs. So you can take your monitor, your sensor, plug in to your tablet, and take your weight, and then your blood pressure and your heart rate, and that all gets sent off to the health authority. What I like about this picture is what is missing when you use a tablet? Who no longer is involved? If you look at these three pictures, yeah, the health practitioner. So now the person themselves can actually take the readings. They can see their own reading. I was actually just listening to a podcast a couple weeks ago about how the introduction of the stethoscope all of a sudden started medicalizing health and how it took away the doctor and patient relationship, and now the doctor can bypass the patient and actually just listen to their vital signs. So I think it's actually quite interesting when I saw these pictures. So this is your exercise to want you to lift up your technologies and wave them around, because this is one of the huge benefits of it. So just to look around and see how much technologies are out there. Oh, you don't know everything? There you go. So it's just to show that we have our devices all out there, including pens. So it's a system that we can use to link everyone together and to have people in control of their own health. The other thing that I like about using technology is that other assistive devices tend to be made for the person with a disability or a frail senior, and it really targets them and identifies them with a disability. But using these technologies, people actually blend into society. So, what I really wanted to show with this slide was how public health and technology and seniors interplay with each other. So, just like Alexa had with privacy concerns, I think that there's that concern with technology as well. There's concerns about objectifying people and really alienating the client if technologies aren't introduced correctly. There's also technology, the interplay between technology and seniors. So as I mentioned, the barriers as far as financial and also user-centered design for them. And then the one I'm still trying to tease apart is public health and seniors. I went to a public health conference in 2011, and I was surprised because there's only one mention of seniors in the whole conference. So I thought, oh no, I did the wrong thing. But I think it's just really recognizing that it's early childhood, but development is important, modifying behavior is important, but remember to include seniors in public health as well.
Questions?
I do have thank yous, but I had a typo on my slide, so I'm not going to post it. So I forgot to do my thank you. So thanks to Brenda for being such a wonderful person to learn off of. And then I had a really good team actually at the Senior Action Plan team. Lee Modell helped me with my consultations. And there's also Rosie Hall and Phil Davidson and Karen Archibald and Kristen Manning. And then Trevor actually helped me get my practicum. And he was my second reader. And
Claire.
Okay, so questions for Marcy?
It gave you the longest walk there. In your research, do you come across any groups of seniors who are more likely to adopt technology, different communities, urban versus rural countries, anything like that?
I didn't really get into that. I suspect actually urban would be more so. With rural populations, there still are problems with internet access, and that is getting better. But yeah, I didn't focus on it in particular.
Thanks for your presentation, Marcy. I was just wondering, with what Kara said about the accelerometer in the cell phones, are there apps for that? Pulse monitoring? I know Lifeline recently released the new, it's Karis is the one that has the accelerometer, but if people, and more seniors I'm seeing, are using cell phones, if they already have that technology, it negates having to pay this monthly fee. At the same time, if there's not someone monitoring that as regularly on the other side. I'm curious about that technology.
I'm trying to remember. I think it's called Valma. I'm trying to remember it. VALMA. What I found is a lot of these technologies are really, they've been past the prototype stage and they're just in pilot testing. They haven't been released yet.
Very up and coming.
Yeah.
Can you just, now that I'm thinking about Margaret with her methodology, can you just,
I go through my methodology?
can you go to your methodology? Do you have
Yeah,
this?
I was going to go through that, but then I was at 15 minutes, 30 seconds. So,
Okay,
but,
can you tell us
yeah,
that?
so my method, I can tell you now.
Yeah.
So my methodology was I actually consulted with policymakers and researchers. So I did 22 consultations with BC, Alberta, some in Ontario, one in Pennsylvania. And then as far as my literature review, that they really helped to find the great literature for me. And with my literature review, I looked at over 400 papers and then isolated it down to about 23. And what I ended up doing was separating it into different categories of policy and concepts and that, the 4 different categories.
Who are the people you consulted with? Who did you talk to? And how did you find them?
Some of them were within the ministry, so I did consultations within the Ministry of Health and then the Ministry of Social Development as well. And then the researchers were people that I found with the papers that were popping up. Actually, SFU and UMT are two really strong universities focused on it. I didn't get a chance to talk to anyone at UMT though. Is that just perfect?
Thanks so much for the wonderful presentation. I think for me it was a nice reminder to remember that part of the population and stuff like that. And I appreciate your advocacy and all your passion that you bring to it. We do talk about health inequities. With technology, it's getting cheaper, but it's not cheap. So do you foresee subsidizing or someone with a cognitive impairment being able to actually have an iPad or something with a touch screen to help utilize these services?
That's actually, that was the second half of my of my paper was looking at adoption, and my personal, having worked with equipment for a long period of time, there is no support for seniors in BC. So I think it's something that needs to be addressed. What that looks like, I'm still actually kind of debating because the program that we have right now with the Ministry of Social Development for people with disabilities, I actually don't think it's been very enabling. It's actually brought greater inequities, I think, and
Yeah, it just seems like there could be, you have to dive in a little bit deeper, but it seems like if people don't have to go to the doctor so much, how much money are we saving?
Yeah.
That's really not expensive.
Yeah.
Just a question about the technology used in the healthcare system. There's a thought out there that the increasing senior population is going to bankrupt healthcare, and that's actually not quite true. It's a lot to do with just increased service usage across the board, as well as increased use of technology in healthcare services. So I was just wondering if cost of healthcare delivery came up at all when you were looking at the technology.
Actually, I think right in my head, it's very tough to, I guess going back to Kate's comment too, it's very tough to determine how savings are made because it's so intertwined with everything. And we don't have the data to analyze that. So, but yeah, I tried to look for cost effective in my scoping review and cost analysis, and I found only one paper that examined that. So, quite tough.
Thank you for your presentation. Just really a comment. Often when we think about the technologies, particularly computer-based technologies and so forth, we sort of assume that the default, the reason for non-adoption is because of the complicated nature of the environment in which you're working. And that may be true, but it's also about manual dexterity and nanotechnology. Devices are getting smaller and smaller and smaller, and so both harder to see and harder to manipulate if you have large stump-leaf fingers like I do, for example. So it isn't just the computer side of things. It's actually, other dimensions of that design. And I'm sure that this is something that you've come across in what you're doing.
I'm quite interested because the latest smartphone I think is coming out with iScan. I don't know what that looks like, but I'm quite interested to see that. In my previous career, I actually looked at interfaces on how to link people where you didn't have to use any dexterity. You could use your head to activate the device. So there are ways around it. But the problem is that it gets more costly when you start doing all those interfaces. So it'd be better to have it built in at the beginning.
Any final questions? Okay, well, thank you, Marcy, for Before we close, I actually want the whole group that presented today to stand up and just acknowledge all 5 of you. So the other 4 who are in the room, please stand up and let's give a session. And I want, at the same time, I know also that there's some people that were field guides or working in the placement settings. And so I just want to express a special thanks to you for attending today. We really appreciate it. It's what allows our students to go out and really gain an in-field real sense of knowledge. And so I just want you to know how much we appreciate you being present today.